All right, good morning, good afternoon, good evening, everyone. Thank you for joining. My name is Allison Pack, and I'm a program officer at Johns Hopkins Center for Communication Programs, also known as CCP. I will be your moderator for today's event, for today's Q&A session, and just a quick tech update. We will be having live interpretation, so please check your preferred language by clicking on interpretation at the bottom of your screen. And also, please keep your mics muted throughout the session unless you are asking a question or told to unmute. We do encourage you to ask questions via the Q&A option on Zoom, and also to respond with comments, thoughts in our chat. And we also do encourage you to have your cameras on if your bandwidth allows. And as Danette mentioned, please feel free to introduce yourself in the chat with your name, personal pronouns, organization, position, location. All right, so as a member of the team that helped to develop some of these, or the provider behavior change tools, I am very excited to welcome you to our first provider behavior change tools live question and answer session. We hope to enhance your understanding and use of the suite of PBC tools, which include the provider behavior ecosystem map, the PBC toolkit for FP, and the PBC monitoring and evaluation brief. So we hope that you were able to view our instructional videos that are available both in English and French on YouTube, as these videos provide a clear and actionable guidance on using the tools. But today we have a unique experience and our opportunity to hear live from practitioners, researchers, and some of the tool development team on their experiences and lessons learned from implementing the PB tools in their context. So we hope to, as I mentioned earlier, have you all ask questions to our panelists. So please utilize the Q&A function on Zoom, and then also to utilize the meeting chat for thoughts, comments, feedback, or sharing your own experiences. So with that said, I'd like to introduce our panelists. Let me please introduce first Danette Wilkins. They currently serve as a program officer for sexual and reproductive health under Breakthrough Action with Johns Hopkins Center for Communication Programs. In this role, they apply social and behavior change, SBC approaches, to SRH programming that engages healthcare providers, men and boys, and sexual and gender minority youth. Danette also contributes to gender mainstreaming and integration across global offices and projects. They have over 15 years of experience designing and implementing global education, research, programming, and training in Africa, East Asia, or Eastern Europe, Latin America, and the Caribbean, North America, and Asia. Danette has worked across a wide range of health and development areas, including agriculture, economic growth, democracy and governance, education, environment, and natural resources, health, and gender. Our next panelist, we have Dr. Camden Hoffman. Dr. Camden Hoffman is a distinguished expert in public health with extensive experience in SBC. She currently serves as the technical director for SBC at Chorus International, where she leads the SBC and social accountability efforts for Momentum, Integrated Health Resilience, also known as MIHR. Through Breakthrough Action Research, she developed and she supported development and the socialization of the research and learning agenda for provider behavior change. And as a member of the SBC for Service Delivery COP, she contributed to prototyping and the development of the Breakthrough Action PBC toolkit. So today she'll be sharing with us how she used that tool at MIHR and the development of also a PBC toolkit package that's available online that's aimed to support implementing partners to use the toolkit more easily. It has a video series, a roadmap, slide decks, adaptations, and a draft agenda. Our next panelist I'd like to introduce is Sahar Gul. Dr. Sahar Gul currently works as an independent program design and strategy consultant for SBC delivering technical assistance to several national and international organizations, including Pathfinder International, the Aga Khan Foundation, the Aga Khan University, and many others. Prior to this, he served as Senior Global Technical Advisor for SBC and Health Markets with Pathfinder International's Global Technical Services Department. And there he provided support for programs across 20 plus countries. He also served as the technical lead from Pathfinder from the Frontier Health Markets, FHM Engage project, managing USAID investments in private health sectors across 11 countries in South Asia and Africa. And I will also be contributing to the panel. Like I said, I'm Allison Pack. I am a program officer at Johns Hopkins Center for Health Security. I also worked on the development team for creating the PBC toolkit, as well as the videos that you've seen online, the instructional videos. So I'll be happy to contribute and answer any questions that you may have. So with that said, I will do less talking and like to open up some questions to our panelists. The first question I'd like to start off with, and whoever would like to kick this off, please do. We would like to hear more about how you ended up using some of these tools and why you decided to use the tools.
I can go ahead and kick us off. Thank you, Allison, for the wonderful introductions, and so happy to be here and see a lot of familiar faces. So as you mentioned, Allison, when I was with Breakthrough Research, we did develop the research and learning agenda for provider behavior change, which showed the importance and the underutilization of PBC in SBC. I also co-authored a peer-reviewed article with Zaher and others looking at considerations for PBC in family planning provider behavior change. Being in the SBC service delivery community of practice, naturally being prototyping and being involved as a user. As we know in SBC, if you're involved early on, you're more likely to uptake a tool. And knowing that that PBC was so important, I advocated to Mer that we should definitely have this in our core work plan and our field work plans as much as possible.
Zaher, would you mind jumping in?
Thank you. Good to see you again, Cameron and Allison. In 2020, I had started with Pathfinder as a senior advisor for SPC, and I was working at that time with the global medical director. We were developing a continuous quality improvement framework, and both of us were coming from a health systems lens, and we were very strongly of the opinion that quality, the clinical competence part needs support for the behavioral competence part as well, to not just be able to deliver on those standards, but also to be able to focus more on the person-centered aspects of care. And we started looking for resources, and the PBC ecosystem map kind of jumps out. It synthesizes so much learning from all the work that's gone into this space, and it just seemed like a natural go-to set of guidance and toolkit and resources to try and start thinking about, how can we focus on quality of care that acknowledges providers as individuals, and as a lot of them being women in their own sort of, cultures and contexts. So we started thinking about how to mainstream it, but first it informed our global guidance piece that we were working on, and then we operationalized it in a few of our countries, using the tools to varying depths of intensity. So yes, I'm a fan, and I'm sure that kind of is not a secret at this point. So.
Thank you both. And Danette, would you mind jumping in and sharing a little bit about why these tools were developed and a little behind the scenes of why these were created?
Sure. And to maybe get a little audience participants, if you could share in the chat just which of the tools you're familiar with, that can just help us in helping to respond and ensure we're providing sufficient information. I was involved, I came into the late stages of the development of the provider behavior ecosystem map, and Zaher, just so great to hear about just the enthusiasm and interest and utility of this tool in really helping to understand that there are so many influences across different levels that are always impacting providers and the quality of care that they're able to deliver in health facilities or in other places where they're delivering services. And so it was really through this map process and opening up our own minds to this entire universe of what influences providers that we started to understand that it was necessary to go beyond the map and really be able to bring teams together, multidisciplinary teams, whether it's providers or leadership or community members or folks with different project management skills like monitoring and evaluation. That was really important that all these partners and stakeholders came together to be able to then look at their particular universe and their context of what influences providers, and then start to identify what were some of the priority behaviors, there we go, the priority behaviors that they would be able to address through a particular initiative or project, taking into mind all of the constraints that there might be around different resources. And so after developing this map, that led us to then develop this toolkit that really breaks down the stages of bringing together a multidisciplinary team to be able to identify these priority behaviors among providers, and then to together develop different solutions to these behaviors. And by that, I mean, we're not viewing providers as a problem. We're viewing providers as individuals who are always dealing with different constraints and facilitators to being able to provide high quality care. And so then what are the behaviors that are most important to influence so that we can achieve positive health outcomes at scale within whichever community that you're working in. And so after then developing this toolkit, it became apparent that another critical part of program design implementation is that monitoring and evaluation. So we wanted to also follow this through line of project implementation, the program cycle, as we call it sometimes, to then provide guidance around what can you do to monitor and evaluate these interventions that you're now developing to be able to better address these priority behaviors and improve health outcomes in a particular community. So the M&M brief, monitoring and evaluation brief that we developed it's very exploratory, and we want others to take that brief and build on it based on their own experiences. But it's a starting point for us to understand what it means to be taking this socio-ecological systems lens when it comes to provider behavior, and then working to address these different factors and measure the impact that our interventions are having. So I'll stop there and would love to hear more from the other panelists about the work that they've been doing.
Thank you, Danette. And I believe we also have Fiona Amato on the in our session today. She has volunteered to jump in and share a little bit more about her experience using the tools, as well as why they use the tools.
Yeah, hello everyone. This is Fiona Amato with CCP in Uganda under the USAID Social Behavior Change Activity. So we ended up using the PBC toolkit because we noticed that when it comes to family planning, we're not progressing as a country. And one of the things that actually people say is a barrier are the health workers. So they say health work is an attitude, they don't know how to counsel, it's the skills. So as we're trying to create solutions, how do we work with a health worker? How do we see that they provide quality services? We were chanced to come across the PBC toolkit, and we were like, oh wow, this actually doesn't look at the provider as a single person, but it also looks at the other issues that affect this provider, because most cases we are quick to judge, they are so rude, but we don't know what is actually making them do this, So that is how we're like, oh, this is going to be able to let us understand more what are the issues they're facing as providers. How does that affect the way they provide their services to these clients before we judge and end up concluding that the provider has a bad attitude, they are so rude. So for us, I think the PBC toolkit was offering us a 360-degree way in which to find out the underlying issues that these people experience, because they're humans just the way we are, but also how we can work around that to make sure that they offer quality services. So that is one of the things that led us to implement or use the provider behavior change toolkit. And we started it off with the family planning component, since it's where we struggle a lot as a country. Thank you.
Thank you, Fiona. So as you can see, the common denominator through all these different contexts is really just highlighting the importance of considering all the factors, the diverse factors that influence facility-based providers, and then also how these factors interact. So these tools really allow the user, as you've heard from the panelists, to observe that complex network of factors and the linkages between those factors in a more comprehensive and holistic way. And then also the ability to and option to design programs and interventions to address those behaviors. And following up with the M&E brief that Danette mentioned, to also monitor and evaluate those interventions as well. At this point, I'd just like to open the floor to the panelists. Anything else to add in terms of your experience on how you've used these tools?
So I can jump in with that. When we sort of approached it, tried to get our head around it and understood it, there was 4 things that jumped out as definite use cases and value for the tools themselves. The first was that, as you very rightly said, it's a complex process. So what the toolkit did and the ecosystem map did was it added a lot of structure to the complexity that otherwise would have been a lot of guesswork. Another thing that it does is that it kind of takes it starts at the starting point, goes to the end point, and creates tiny quantized steps in the middle to look at individually. And the highest value that we felt that it gave us was that it helped us turn into what was most likely to be a very intensive research process into something that could be led by implementation and operations, boots on ground folks, and also provides this mechanism for how to engage audiences. Otherwise, these 2 pieces kind of remain a question mark a lot of the times, and that compromises quality. And we felt that these 4 value additions were really useful for us at the central level, and then for our teams on ground as well as we utilized it.
I can go ahead and jump in next. So we decided to roll out the orientation of the tool first in Khartoum, Sudan, last year in April. And the team, when we started going through the orientation, they said, this is a lot to absorb. I don't really know where to start. Is there like a checklist, or is there a roadmap or something that can help me understand this a little bit better? Because all these handouts, and they're not even in Arabic, and they're family planning, not M&H. And so I said, I'll take that back and think about what to do. And then in June last year in Juba, I did a similar orientation with my colleague Kenyi, who will be presenting on Thursday morning. And the same thing happened. And I realized that we really needed something that would sort of break down each piece and sort of. I said to my colleagues, I said, would it be helpful if we developed sort of like a roadmap that would take us from the diagnostic phases and explain what each of those pieces meant, how we synthesized, how we moved up into action planning, and what all the important pieces were. And so I took this flip chart piece of paper from Juba all the way back to Roseville, North Carolina, and developed it into a roadmap in a slide deck. And what Allison was talking about earlier, we thought it would be very helpful for all of our teams, as well as other implementing partners, to develop a PBC toolkit package. So it's a series of 7 videos that are short and talk about each step, and then provide the slide deck training materials, the adaptations that we made in fragile settings, and those were all based on field feedback from Sudan and South Sudan, and then the agenda as well. I'm very excited. Someone from UNICEF working in Lebanon and Gaza Strip reached out to me to use this tool, and we're going to touch base in about a week and a half to see how she's using that in those contexts. I'm going to try and document that as well. In Bor County in South Sudan, we've started to roll this out. And in the M&M, as Danette mentioned, we are using the provider authoritarian attitude scale that was developed by Breakthrough Research. And the first primary healthcare center, PHCC, that we're working in, where we did the baseline, we had very low authoritarian attitudes. And we can make a small assumption. We can't make this fully, but we have been in this PHCC for quite a while. So there's a lot of factors that have probably already affected the providers. So we are going to go into a non-MER facility and try and do that again and see if we have a different baseline and use the tool again in another PHCC in Bor County. We are also using, as mentioned in the M&M guide, as we use throughout all our countries, the most significant change, a qualitative complexity-aware methodology, which allows for unintended outcomes to be discovered. And I think because of the complexity of this model, MSC lends itself to being able to discover those types of outcomes that we wouldn't necessarily find from a straightforward questionnaire, whether that be quantitative or qualitative. Over.
Excellent. Thank you, Camden. And definitely keep us updated as those projects roll out and as you gather more information. So just a reminder, if you have any questions for our panelists as they speak, feel free to drop those in the chat or into our Q&A option within Zoom, and we'll be happy to answer those. But for now, I'd like to open up the floor again to the panelists to discuss some challenges. What challenges did you face while implementing these tools? And Zahir, I see you nodding already. Would you like to start?
There isn't a single task in global health or health systems that doesn't come with its very unique sort of challenges that one may think, oh, I've got this nailed down, and then you move forward and then things start coming in from the side and all over the place. And I think we, as the technical sort of go-to person to resolve a lot of these complexities when we were applying this, they were, bulk of the challenges that came in, the first and foremost, and I think Camden also referred to this a little bit, is that because it's of the complexity of the domain of provider behavior change itself, it's a whole series of steps that need to be completed. And while they're all valuable, when the kind of feedback that we got from boots on ground and teams on ground was that this has to be undertaken within the larger ambit of existing and ongoing programs and investments that look at various aspects of the health system. And of course, because Pathfinder is strongly sort of aligned towards public sector technical assistance, so we dealt with a lot of competing timelines and competing priorities. We had to deal with a lot of a lack of appetite from the public sector and even from donors in country who were wary of investing an extended amount of time to do the deep dive, the diagnosis, sort of identify some of those solutions, but then they also took further operationalization to be able to be rolled out even after using the toolkit. So we had some challenges in trying to sort of lock down timeframes that must be associated with a rigorous application of the tool. There's always a rush to do things, and engaging with decision makers and implementers and even providers themselves was sometimes challenging in the field because of their own competing priorities. So, I mean, we felt that the toolkit has its applicability, but before we start rolling it out, we need to be clear on the expectations of the timelines and, of course, the associated costs that are very critical to anything being done well. So that was sort of the biggest challenge we felt. And I think that just means that greater groundwork is needed for toolkit can be rolled out more rigorously in terms of timeframes and costs and folks to involve, and building up that timeframe is important just to set off.
Hi, can I come in?
Yes, welcome, Mabel. So Mabel is another one of our panelists. I can do a quick introduction of you, Mabel, if you don't mind.
Sure.
All right, so Mabel is a vibrant SPC specialist with considerable skills and expertise in designing and implementing communication programs, building partnerships, stakeholder mapping, and engagement. Over the last 9 years, Mabel has worked with USAID Maine Project, delivering innovation in self-care DISC project, and USAID/Defeat TB project to boost maternal and newborn health. Also the DMPASC self-injection and TB communication and awareness in Uganda. So additionally, she worked with USAID in the Communication for Healthy Communities, CHC, under the OBULAMU campaign to design and coordinate implementation of health community interventions and campaigns in the areas of HIV and AIDS, TB, malaria, family planning, maternal and child health, and nutrition. And currently, she's working at CCP under the USAID SBC activity as a human-centered design specialist. So Mabel, we so far have just been discussing how the tools, or how we've been utilizing the tools and why. Fiona gave us some great examples. And we'd also like to open the floor to discuss any challenges that you've been facing about the tools.
Thank you, and I apologize for being late. I was caught up with a lot of technical issues, but thank you very much. The challenges, we've had quite a number of them, and the biggest one was time. The time for implementing the tool. So when you come to our context as Uganda already, the health worker doesn't have a lot of time, because you find like 2 health workers at a health center and they're dealing with a lot of clients. Now, this was the tool that needed a lot of time for it to be administered. So that alone left us with not so much to do. The tool was long. The toolkit is really long. So we needed quite a lot of time. We needed a lot of hands on deck to do this, but we didn't have that time, unfortunately, to engage the health workers. They had to keep going and coming back, and it really broke the process. And also when we came to the clients, they had already waited for a long time to receive the clients. And now here we were, and we had to engage them on the toolkit. So they couldn't really give us their best because they were already tired. They were just looking on, their clock to the next minute to leave. So that didn't give us the best quality. So we had to try and work in the shortest time possible. And I don't know if Fiona said this, but at some point we had to adapt the tool as much as possible, just to make it a lot shorter, to be suitable for our context, That very long toolkit was just not working for us. And then the other thing, because it's sort of in our health system, most of the people engaged sort of thought that we or expected to be reimbursed a bit. And when that didn't happen, it was a problem. The other thing was around following up with the action plans. We came up with action plans that it was supposed to be, but the following up was really hard. Because of that, again, the health workers are busy. Sometimes the IPs we're working with are also busy. The districts are busy with so much. So following up with the little hands that we had was another thing. So we came up with action plans, but just to be honest, the following up of those has not been the easiest thing for us to do. And then you would find that some of the things in there, like some of the pictorial, the scenarios, when you came to the client's toolkit, they weren't so relatable to our audiences. So we ended up, as we were adapting the toolkit, we ended up using like only 2 or 3 pictorial scenarios. Those are the ones that our audiences would look at, and identify with. So most of the other ones we had to drop, which were really good, but because of how they are, or how, the format in which they were, the audiences felt like they weren't speaking to them. And also the other very big one is that the toolkit was supposed to diagnose SBC issues, mainly. But when we came to apply it, the issues that were coming up were systemic structural issues, which we couldn't do or act upon as us. So we had to still bring them up to the district or the Ministry of Health. And of course, most of these, the district will tell you their hands are tied, and when you take them to the Ministry of Health, this is going to take the longest time for some of these structural things to change. For example, you will see that most of the health workers, they'll tell you we are people, we are humans, and we are acting like that because of what we are going through. A health worker will tell you they have never gone on leave for the last 5 years. And they tell you we are also humans, we are tired, and all that. So sometimes the attitude with which they show or they work on their client, it's because of what they're going through psychologically. Now, when we come with our SBC, they feel like we are not helping. Yes, we shall get those issues, we shall diagnose them, but we are not getting to the root cause of what the problem actually is. So most of the things ended up having to go back to the district health teams or the Ministry of Health. But unfortunately, up to now, most of those have not been solved. And like I mentioned, as SBC, we can only do so much. We can't address most of those. So that left us with our hands tied. We have an action plan, but we can't, do much around it. And of course, the other thing is also the district has a lot of competing priorities. And even when we found out, we diagnosed some of these issues, the district didn't want to own up to some of them. Yet they're actually there, they're happening. So of course, the facilities have been able to find solutions to a few things they can, but unfortunately, most of those structural things hasn't happened. So it leaves us with a question of how much we get to use that tool in actual sense. Thank you.
Thank you, Mabel. You've provided a great example of how this toolkit is truly you're able to adapt the toolkit to multiple different contexts, multiple different health areas. So I saw some questions in the chat about, yes, the toolkit that we have published is focused on family planning, but there are ways to adapt the toolkit to different health areas and also to shorten the steps or the time commitment that it takes to implement the toolkit. It is a rather lengthy process if you do all the steps, but as Mabel has demonstrated, you are able to select and utilize the tools that most apply to your context, that will be the most efficient to get to the finish line. And I know someone asked in the question, the Q&A, if Mabel could share the shortened version. So Mabel, if you have any documents, and I think we have one through Breakthrough Action about the steps that you took, or if you'd like to outline that for those for us now.
So we actually had we had a workshop as us and the people that were going to implement this. And we sort of went through a full week of, we didn't really dwell with most of the toolkit, but some of the things that we thought needed to change. And I think Fiona could have mentioned this. Even earlier on, that the toolkit was focused on FP alone. But if you go to most of the facilities, FP is not like the biggest problem. Yes, it is an issue, but it's not the biggest. You'll find things around MCH, even HIV or TB, all these other quality issues around the provider. And most of our providers are all round. So the provider will not only be focused on FP. So you will see that in our toolkit that we came up with, we have scenarios that are focused even on other health areas beyond family planning. And you will see that as we adapted, in the first round, so we had around 3 rounds of implementation. In the first round, we used that tool the way it was. That's when we were like, okay, we needed to make some changes. In the second round, so before the second round, we sat as a team and tried to change here and there. So when we went out in the second round, we were asking these providers, for example, what are those things that help you to do your work well? What are those things that affect you from doing your work? Now, they would give us the issues and would qualify them. So this helped us to sort of spare some time, save some time, because going factor by factor. So where some things didn't come through, would probe. But someone, of course, will talk about relationship with their, with their co-workers or the district, what is doing, all the structural things. So they would give us these issues and then would qualify them under each of the factors that we had. But this helped us to have the discussion more open. And of course, you'll see that the things that were on top would come out clearly. Those that they didn't mention would probe. Sometimes they'll say that factor doesn't affect us in any way, the environmental issues with some. But we're just trying to see how do we save time, given that they're already busy, their schedule is already tight. So wanted to make sure we do this, help them, but also try as much as possible and make the process easy. So Fiona and I can share some of those, I think, on email, because it was a longer process also. And we can always engage for those who would want to see how we worked it out.
Thank you, Mabel. And that's a great example of how this toolkit really thrives off of communication and working with providers, right? So really understanding their circumstances. And also there's tools within the toolkit to work with clients to get the perspective of multiple different people that are working in that health system. And Camden, did you have any challenges you wanted to share with the group?
Well, I think I echo a lot of the challenges that Mabel and Zahir had already mentioned. I think one additional one is that when we did our original training of our core implementation team, due to migrational patterns, some of our CIT members had moved on, and we had to reorient new members. And that's something typical in a fragile setting where we work in our countries. And so that's something that, I think thinking ahead, sort of like the in case methodology of some of the possible unintended consequences beforehand might be helpful, so that you're already anticipating what you might want to be able to troubleshoot later on.
Great. Yeah, always have a backup plan. You never know what's going to happen. All right. If there are any questions for our panelists at this time, please feel free to drop them in the chat, and focusing these questions on provider behavior change and the experiences and lessons learned that our panelists have shared. So while we wait for some questions to come through, I'd also like to open the floor. Oh, here we go. Carlene, she's asked, how do you get providers to be more motivated when they know they generally have high workloads? So several of you have mentioned how busy providers are, and it's very difficult to even just get time to have these discussions with them. Could you share any personal experiences about increasing motivation? And then also, and perhaps those are incentives. And Carlene has mentioned not necessarily financial. Are there ways to improve their level of empathy? Do any of you have examples of that?
I was going to give a recommendation. Oh, Mabel, do you want to go ahead?
No, it's okay. So when we spoke to them, they did mention some things that weren't really financial. Number one, which is really interesting, is appreciation. Just appreciating them, feeling like they're appreciated by their leads, the facility lead or the facility in charge, but also the clients themselves. They told us they feel hurt that they are going to work on a long line of clients, and then at the end of the day, they feel like they still don't appreciate the service. So we're just trying to bring that whole thing of appreciating, and they feel like if at least I'm appreciated, it might not be the financial, but they feel like my service here, creates some change. And the other thing was about the professional development. There's always a lot of opportunities around provider as that the Ministry of Health brings, that districts have, and implementing partners. But they were telling us sometimes they are going to pick on one provider for each of these, and the rest are going to be left out, and they all don't feel fine. So they were like, if we all get this opportunity to feel like at least I'm going to have some professional development of some way or another. If there's a training, let me be considered to improve my skills, and knowledge. Specifically, they said those would go also a long way. And also, the thing I talked about already, they feel like they need some time for themselves and their families. They don't take leave. They work Monday to Monday, almost Monday. So some of them will just decide to be absent over the weekend, because they are not given that time officially. So then a woman will go to give birth on Saturday and she won't find anyone, and then problems come. So if there is that organized way in which a provider will know that in this week, I will not work, I'll be on leave, then he said, you are humans, you shall also feel better. So I won't have to be absent from work, with excuses that I lost someone, I'm sick, when it's actually wrong. So some of those things, they said, would go a long way with helping them be better. Even, and interestingly, and Fiona could attest, most of them said it's not, the issues are not really money. When we were speaking to them, they would actually take us on the side after the main discussion and tell us, for me, my biggest issue is this. And it was not always money. It was a relationship with how they relate with their in charge, or how the fact that they've been at work for the longest time. They don't feel like the in charge appreciates them. Some of those things which they could, they could find some solutions to before they address the bigger structural issues.
Alison, just to add something that's just an example. So for maybe those who are familiar with our setting and those who are not, so we have boreholes where we fetch water. So the providers told us, you see, if I go to fetch water in the evening and the community doesn't allow me to fetch water fast, trust me, I'll wait for them at the facility the next day, and I'm going to have them in a sense that you didn't recognize I'm your health worker, so you should have let me fetch water first as a way of appreciating my services. So that was kind of like, they're like, no, when they come the facility, I'm either going to be rude, I'll not be happy. So it's those little things that actually they mentioned that could get them do their work well.
Thank you, Mabel and Fiona. Just to echo, and Camden, I know you added this in the chat, but recognition and appreciation goes a long way. And just to add, Breakthrough Action this year is also working on updating or editing the current ecosystem to also be applicable to community health workers. And we saw appreciation and recognition strongly come through in our literature review and our key informant interviews as a key influence on community health worker behavior. Camden, over to you.
Thank you. Thank you so much, Mabel and Fiona. You bring up some really, really good points that I had as well. And one thing that we've been discussing and that came out of the Africa Society for Social and Behavior Change Summit from July 2nd to the 4th, during one of the plenary panels, one of my colleagues, Isufu from Niger, was talking, the question was asked, how do we professionalize SBC? And this has been a big question in our field for a long time. And so thinking through that and how to incentivize providers once they do change their behaviors based on this toolkit, maybe we can think about some sort of accreditation or CEU type of model where they actually get recognized and have those accreditations in their portfolio, which would raise their status, give them recognition, and actually lead them further along in their career path. I also I saw Alice in the chat. Alice, it's great to see you from Clear Global. Your question about marginalized languages and such, we do plan to work with, bring this down to the community health worker level. That was one of the things that I brought up during the ecosystem and the PBC toolkit development, was how do we bring it down to CHWs? And I think that will be a critical issue that we'll need to address. And Alice, I've worked with Alice before at Clear Global, and they have the ability to translate materials and all types of things in over 300 languages, including indigenous languages. So I think it's a really good idea to think about those that are excluded due to language issues, and that's something we should think about. And then I saw someone, in Mali, how do we use provider behavior change tools? I just wanted to also let everyone know that in Mali, we're using Breakthrough Actions and Pathways model, where youth and providers come together and use a card deck to improve their relationship. And we've seen positive outcomes from that. And we are replicating that and doing a 9-month post follow-up survey among those that participated in the original pathways to see if they are still implementing some of the changes that they had started after they implemented them after the pathways involvement. Over.
Thank you, Camden. Thank you for those examples. Zahir, anything to add in terms of incentives or motivators for providers?
Yes, thank you. I think there were two critical pieces of learning that emerged from this application process that we did over a 2-year period. And one of them was that where the factors that are driving those behaviors, once these have been identified, it's useful to sort of bring folks together to conceptualize a mechanism of change. Because a lot of the times those solutions are so systemic and health system and structurally oriented that it's often beyond the purview of a behavior change program to be able to implement those. So we found mechanisms whereby simpler approaches, for example, VCAT or value clarification and attitude transformation is a very established sort of approach. It's been there long before PBC came in. But one of the things we identified was that programs very often will try to focus on values, social and cultural values of providers, and trying to shift those to be more favorable towards person-centered care, Whereas some of the feedback we received from this process when we were talking with providers was that personal values and professional norms of practice and standards are two very different domains. And programs might be better suited to shift their perceptions of norms and values as to the quality of care that's mandated, rather than trying to shift their personal, social, religious, or cultural values, which never really works in that short time frame. So focusing on standards of care, improving their understanding and linking it to role models and recognition of good performance is a simple mechanism, well, simple conceptually at least, implementation is a different story. But at least we have evidence that it works, and it can be embedded within existing structures without needing a lot of fancy new interventions being brought into the system itself.
Thank you, Sarah. And I think you touched perfectly on another question we have in the chat from Shilpi. So, and feel free for anybody to jump in, but just to expand a little bit more on facing health issues or provider behaviors related to political and religious beliefs.
I'll expand on that just a little bit, very briefly. There are mandates in place for the standards of practice that must be delivered. In the absence of a clear performance tracking and quality tracking mechanisms, those mandates kind of they disappear, and providers sort of have to fall back on their best guess on whether this is doable or not. A provider may actually feel that it's fine to give a young unmarried person contraceptive method. However, they may not do it because they don't believe in it, but rather because they are living in their community where norms can create a backlash. And sort of understanding that legal mandates and regulatory provisions, they have to play a role in how we approach provider behavior change. It can't just be that we focus on their thoughts and beliefs disconnected from the larger operating environment. So most regulatory frameworks and legal mandates for duty of care do make these provisions, and they do impose those those elements related to duty of care towards their clients. And I think that's the focus within the health system that should be there, because after all, providers are the experts in how services should be delivered. So linking them to existing enablers is critical, because only then can you create counter narratives and arguments to address harmful norms and opposition from religious and political leaders. Without that legal backing, it's very challenging for teams to sort of deliver those kinds of messages in environments that are already challenging and potentially hostile to the work that most of our programs are doing.
Thank you so much. And I'm sorry I'm taking like when I'm switching on my audio and talking. I had a follow-up question for this, and maybe if you do not have an answer right now immediately, maybe you can like email me later on. So has there related to this and like observing any trend, has there been any incident where any healthcare provider has been able to sort of leverage any information that she has collected through this tool for, say, more resources, whether it's in terms of like, say, IEC materials, or maybe more medicines, or I don't know, maybe more funding to like support any like group event that she's hosting. Even small things like basically and not even like healthcare workers, but maybe people like us who facilitate these kind of methods. But have we been able to like use any of the information for advocacy and like being able to leverage anything? Thank you.
Alison, I don't know if I could speak.
Yes, please.
Yeah, so when Mabel was earlier discussing, most of the issues we found were structural. So what we did is we worked with, we went to facilities where we had implementing the other USG IPs. So for example, there's this particular IP, UHA, the Uganda Health Activity. So when we found some structural issues like stockouts and everything, so we tasked UHA, because health system is part of their mandate, to follow through with the district. And what we've noticed is, because they also have staff that handle that, so they were able to do stock redistribution. Like there are some facilities that have a lot of stock. Then there's also there's poor quantification, the forecasting. So we noticed that through the structural issues we were getting, much as we're looking as well for SBC issues, we were able to flag them off with this IP, who was able to scale them up and make sure that some of those issues were sorted. So that is something that we were able to do as us in Uganda.
Thank you, Fiona. Alison, maybe if I could add something that I remembered. We did this in one of the facilities in the eastern part of the country, and there was something interesting. Clients always had issues with the health workers because they thought they were stealing the drugs, and the medical supplies. So they told us that when this issue came up, they sat together with the clients and told them, before they bring drugs here or medical supplies, you shall always put it up on the notice board. If you come and you check that this drug is not here, this supply is not here, then you'll know it's not here. It will not be as us. So they said this has helped them a lot. So sometimes it's just the communication between the provider and the clients. So that clients no longer say that the providers are actually stealing drugs or medical supplies. They know if we find it on a notice board of the facility, then this is not there. So some of these things just needed a bit, it's structure, but it just needed streamlining. So they know it's not the provider's issue. It's actually an issue ahead or, above them. So some of these things, it's about sitting and knowing this is the problem. What is the easiest way in which we can actually solve them? So for them, that has helped to make their work easy.
Thank you. And with just about 5-6 minutes left in this session, Andre asked a great question to me in the chat, and I'd like to kind of combine it with one of our concluding questions. So Andre mentioned, traditionally, most folks relate to SBC as directed at patients or users, clients, and it's still a new concept for donors and stakeholders when the target is the provider. So I would like to ask the panelists to provide us with a quick elevator speech on why utilizing PBC tools is important, why it's needed, and how to adapt it to create that holistic SBC approach.
Well, like I said earlier, providers, I love when, I think it was Fiona, correct me if I'm wrong, had said providers are people. And I think that we haven't discussed that enough. In SBC, we focused on individuals, households, communities, and expecting that if individuals, households, and communities increase their healthcare seeking behavior, everything will magically change and we will see indicators, improve. But that's not the case, and that's what we have discovered over time, and we have the evidence behind that. So by using these PBC tools and being able to break them down, and like Mabel said, make them easy to use. Some may need one piece, some may need another. It really depends on the context and the setting. But if we don't look at providers, and in the chat, someone was talking, I think Q&A, they were talking about for-profit, nonprofit, exactly, for-profit, nonprofit, community health workers, any other types of providers, they all provide services, whether they're medical or promotional or what have you. And that makes a big difference because of that client provider experience. And we know from evidence that the client provider experience and that dyad is extremely important to improve quality healthcare. Over.
Thank you, Camden. Just to add to where you stopped. For us, for the longest time, we've always said, clients always say the health worker is rude, the attitude is bad. And clients always say, I won't go to that facility because of ABCD. And we didn't try to understand why is this health worker acting the way they are? Why are they rude, in quotes? Why are they always moody? But like I already mentioned, this one woman is going to see 40 pregnant women, in a day. think about it, and they have to go through a long list of processes to help each of these ladies. How much time are they going to give this woman? So like Camden said, this toolkit is really good because it just helps us to diagnose the problem, the behavior issues around the provider beyond just them as individuals. You know, what kind of environment are they working with? What's the relationship with their health, their other colleagues, with their health in charge? What is it, the thing around the reward system in the districts, you know, the rewards and all those things. How, like Fiona put somewhere in the chat, we realize that some people have been working for the longest time, but they've not had, like for 10 years in the same position, they've not had any promotion or any salary increment for the longest time. And then someone who has political power in the district will come and place their relative in a position above, who is not even as qualified as this person who has been there for the longest time. Now, these are issues that we have to think about. This diagnosis tool was able to help us bring these issues, you know, to our faces to know, okay, this is happening. So before we knew that, yes, the health worker has issues, you know, probably behavior issues, but we didn't really come to the point to which the PBC tool was able to bring us to.
Mabel, it seems like we may have lost your connection, but please feel free to type any further discussion into the chat, and I'm sure some people would like to follow up with you. Zahir, would you like to jump in before we conclude?
Sure, thanks. So here's my elevator pitch. Folks have two options. One is to dive headfirst into this very complex domain of service quality and provider behaviors and all of that, and sort of wade through it to figure out, all right, what we might do. The alternative is to be more purposive, more structured, and to be able to sort of identify all the possible options and then prioritize from those. If the second is the objective, then the PBC ecosystem map is the only one of its kind, right? It just helps you not worry about missing something. It helps you be more organized, and the absence of it is just not a desirable state of being for somebody who wants to focus on program design. It's just chaos without having some sort of framework, and this is by far the most advanced that we have at our disposal within the field.
Perfect elevator pitch. Thank you so much. So we are at time. I just want to say thank you to our panelists for contributing and sharing your experiences, your lessons learned, and thank you all for asking your questions in the chat. We do have this meeting recorded, so we'll be sharing a link to that after the call. But also, if you'd like to join, we do have another session, a Q&A session on Thursday with a few other speakers. If you have further questions, that will begin at 8 a.m. Eastern Time, as well as a session in French on July 31st, also at 8 a.m. Eastern Time. So before we conclude, I'd just like to launch a quick poll if you have a second to answer a few questions for Breakthrough Action. We appreciate that. Otherwise, have a great rest of your day.